Today's literature review is entitled Lymphedema and Obesity. Is there a link? It was published by Drs. Mehrara and Greene in the Journal of Plast Reconstr Surg in 2014. As we know, lymphedema is a chronic, incurable condition caused by one of two factors. One, there is a congenital developmental abnormality of our lymphatic system, and this is known as primary lymphedema. Or number two, there is an injury, a trauma, surgery, radiation causing damage of the lymphatic vasculature, and this causes secondary lymphedema. Either way, chronic interstitial fluid accumulation leads to persistent inflammation, fibrosis, adipose tissue deposition, and other factors which result in hypertrophy of the affected limb or area. Significant adipose deposition in late-stage lymphedema decreases the potential for response to mechanical treatments such as manual lymphatic drainage and compression garments, and is often associated with severe infections, functional disability, skin changes, psychosocial issues, and potentially malignancy. For purposes of this review, obese patients are described as having a body mass index greater than 30, and super obese patients are described as having a body mass index greater than 40. Body mass index is also known as BMI. It is known that obesity can increase the risk of secondary lymphedema independent of surgery. This is potentially due to damage to lymphatic vasculature itself. The greater the BMI, the higher the frequency of lymphedema. It's also known that BMI at the time of breast cancer diagnosis appears to be a stronger risk factor for developing lymphedema than weight gain following diagnosis or during treatment. Super obese individuals can develop lymphedema even without surgery or injury. One study of patients presenting to an obesity clinic found that approximately 1/3 of patients had abnormalities on lymphoscintigraphy. Patients with a BMI between 30 and 53 had normal lower extremity lymphatic function, whereas patients with a BMI greater than 59 had abnormal lymphatic drainage consistent with lymphedema. Consequently, a BMI threshold appears to exist between 53 and 59, at which point lower extremity lymphatic dysfunction occurs. It's now clear that obesity can lead to an impaired lymphatic dysfunction. We already know that impaired lymphatic function can lead to adipose deposition and obesity. The adipose deposition in the lymphodematous tissues is in many ways identical to fat deposits seen in obese patients. This lymphedema-associated fat deposition results from both proliferation and hypertrophy of the local adipose tissue cells and chronically inflamed tissues. This is important because this chronic inflammation is associated with both an increased risk and a more aggressive behavior of a variety of malignancies that are seen in obese patients. Other research provides evidence that obesity and dietary changes can profoundly change lymphatic function. Weight management programs, including nutritional counseling and surgical weight loss options, may be potential means of decreasing the rates or severity of lymphedema in at-risk patients. These approaches may translate to improved lymphatic function and increased clearance of interstitial fluid. The negative effects of obesity on lymphatic function may be multifactorial. Obese patients may therefore be at risk for lymphedema because they have a compromised lymphatic function at baseline. They also have abnormal inflammatory responses that can negatively impact the lymphatic system and have impaired ability to regenerate damaged lymphatics after injury. The link between obesity and lymphedema continues to be researched. Increasing evidence supports the concept that this relationship is reciprocal, such that obesity impairs lymphatic transport capacity and impaired lymphatic function promotes adipose deposition. There is indeed a link between lymphedema and obesity. My name is Lisa Berman Sylvestri. My goal is to make us all lymph smart.